the haematologists. Can I ask everyone to please take their seats quickly? I'm one of the haematologists working here at Canberra Hospital. I'm the chair of today's Grand Round session. I have the great pleasure to introduce you to two of our doctors, Dr. Kavya Baby, who's an advanced trainee in geriatric medicine, and also Dr. Sabari Saha, consultant in geriatric medicine. And they're going to lead us through a case today entitled "A Correct Diagnosis is 3/4 the Remedy." So take it away, Kavya.
Thank you. Thanks, Dr. Bennett. Hello, everyone. My name is Kavya, and I'm, like Dr. Bennett said, a geriatric advanced trainee second year. And on behalf of the geriatric department, I'd like to welcome everyone here as well as online to today's Grand Rounds. And I'd like to thank Dr. Yerian, the immunologist, Dr. Furgar, radiology, Dr. Khan from radiology, and a few of the registrars and pathology registrars for their assistance with today's presentation. So without too much delay, I'd start with a quote by Mahatma Gandhi that says, "A correct diagnosis is 3/4 the remedy." And as clinicians, all of us would probably agree with this. Starting off is the case of an 82-year-old Mr. FL, who presented to our emergency department with, as referred in by his GP in November of 2020, with shortness of breath and right upper quadrant abdominal pain. The shortness of breath, as you can see, has been ongoing for a few years, but worsened in the last few weeks, with dyspnea mainly on any exertion and only improving at rest, thereby limiting his exercise tolerance. He did report some unintentional weight loss of around 2 to 3 kilograms in the last few weeks. He denied chest pain. There was no hemoptysis, no infective symptoms. He didn't experience any, symptoms of fluid overload. So there was no pedal edema, there was no orthopnea or PND. His chest X-ray with the GP was unremarkable, although he did get treated with 3 courses of antibiotics for a chest infection just about a month ago. He also complained of right upper quadrant abdominal pain that has also been ongoing on and off for a few years, but denied any rectal bleed or melena. There were no urinary symptoms. There was no renal colic. The pain did not really change with food, with meals, and his bowel habits were consistent. There was no alternating bowel habits. And he did have a recent CT abdopelvis with the GP that showed evidence of fecal loading, but no bowel obstruction, no sinister pathology to be seen on the CT. There was also a hiatus hernia. His past medical history is significant for COPD, for which he's on regular puffers. He did previously have diverticulitis. He's on thyroxine for hypothyroidism. He's on aspirin for ischemic heart disease, for which he's previously had cardiac stents. He's on perindopril for hypertension, on oral hypoglycemic agents for type 2 diabetes. He's previously had prostate cancer, for which he's had a radical prostatectomy in 2003, on a statin for hyperlipidemia. He's previously had provoked DVTs following total knee replacements, on a PPI for reflux, and he's recently had no changes to his medication except the antibiotics that he had about a month ago. This gentleman lives at home with his wife. He's a retired plasterer. He did have a significant smoking history. So he had a 50-pack-year smoking history, but he did quit about 13 years ago. He does not drink any alcohol, and he was still independent with all his ADLs, and he still drove, so he's functionally really good. On examination in ED, he was hemodynamically quite stable, but tachypnic with a respiratory rate of 26 per minute with normal oxygen sats. He was dry, his mucous membranes were dry. Cardiovascular examination was quite normal, just with some mild pitting edema. On respiratory exam, there were mild, just fine bibasal scattered crepitations, but otherwise normal. And he had some tenderness in his right upper quadrant or epigastrium, but otherwise it was not a surgical abdomen. There was no guarding rigidity and no organomegaly. So at the time, there was different thoughts about what could be the cause for his shortness of breath. So could he be having an exacerbation of his previously known COPD? It could be a non-infective exacerbation, or he's not had any, features of, he's not complained of any sputum production, fevers or chills, although he's recently had some antibiotics. He has been immobile more recently, so could he be having a PE? Could this be a new onset of heart failure? But he didn't report any symptoms of the same, and examination didn't really, correlate with this. And with the abdominal pain, wasn't an acute abdominal examination, most likely thought to be due to constipation, could be related to his previous diverticular disease. He's had bloods done, which, as you can see, this is the current bloods when compared to almost a year ago. He did have a mild normocytic anemia with normal white cell counts, but an elevated CRP to close to 40. He did have an AKI compared to about a year ago. His creatinine has jumped up to close to 200 with a drop in his eGFR to close to 30 compared to 50 about a year ago. His calcium level was mildly elevated with a corrected calcium of 2.83, but normal other electrolytes. His thyroid function was also reasonably okay. His liver function, his ALP and GGT were deranged, but barring this, the rest of his liver function was quite normal. And his albumin was also normal. So he's gone on to have a chest X-ray. As you can see, there isn't really much going on in the chest X-ray. There's no features of infection. Doesn't look like he's overtly fluid overloaded. No peripheral pleural effusions. There's no plaques to be seen. He's also had an abdo X-ray for his abdominal pain. That just shows some fecal loading, maybe in the ascending area and the rectal, just some degenerative changes, degenerative bony changes. Now, because we thought PE could be a differential, he's gone on to have a CT-PA that was negative for a PE, thankfully. But as you can see here, it did show some substantial mediastinal and hilar lymphadenopathy. And in the lung views here, we can see some increased ground glass changes in the peripheries with some subtle nodularity. And this is a zoomed in version of the previous image. As you can see, the ground glass changes in the peripheries. So he was discharged home from ED with follow-up to be organized with his GP. However, he saw his GP a week later and the GP sent him back in because his calciums continued to rise. So his corrected calcium has gone up to 3.37 now when compared to 2.83, and constipation's ongoing, not improving despite regular appearance. His shortness of breath is worsening. He's just generally really fatigued and functionally quite declined now. He's not been eating and drinking. He's lost about 5 kilograms now in the last 2 to 3 weeks, although he has no fevers, no night sweats, does not report any renal colic, no features of a renal calculi, basically, no bony pain, and his mentation is quite normal still. Examination again, quite unremarkable, still hemodynamically quite stable. He's dry on examination as expected, but no palpable lymphadenopathy, no cervical, axillary, or inguinal lymphadenopathy, normal cardiorespiratory and abdominal exam. As you expect in his bloods, his corrected calcium's gone up to 3.14 compared to 2.83 with a mild hypomagnesemia, likely because of poor oral intake. So we have 2 issues going on. There's worsening hypercalcemia, and we were thinking of several causes for this. So he does have a previous history of prostate cancer, although this was several years ago. Could it be a recurrence of this with maybe lytic bony lesions? Could he be having, mets to the lungs, although that's unlikely? Could it be a new malignancy? Could he be having a solid organ malignancy like a lung malignancy or bowel malignancy? He's had abdominal symptoms. Or given he's had mediastinal lymphadenopathy, could it be a hematological malignancy like a lymphoma? And then other causes of hypercalcemia need to be ruled out, which I'll talk about. His acute kidney injury, thought to be secondary to his dehydration from the hypercalcemia. He did have a CT abdomen pelvis not long ago, which did not show any features of an obstruction. There were no renal calculi on the CT. And he has been on perindopril, an ACE inhibitor, and a PPI. So AI and acute interstitial nephritis as a cause of the AKI is a possibility. So this time round, he was admitted under the geriatric team, and he commenced on IV hydration while managing his fluid balance. And we screened him for other causes of hypercalcemia, as in we need to make sure it's not a parathyroid-mediated hypercalcemia. So we checked his PTH. Shouldn't be it could be a primary hyperparathyroidism. He also has an AKI. It could be a tertiary hyperparathyroidism. Hyperparathyroidism can be part of a multiple endocrine neoplasia syndrome. It could be familial hypocalciuric hypercalcemia. So rule all this out. It could also be non-PTH mediated. So we make sure the vitamin D is normal. He's not, we don't know he's taking vitamin D, but is he actually not? Could it be a malignancy? So we did some tumor markers, and because of the prostate cancer in the past, we make sure he has no lytic lesion. So we organized a bone scan, which was normal, I should say. The PTH was actually expectedly suppressed at less than 0.5. His vitamin D, so is quite low, so he's not really taking vitamin D. And his tumor markers were thankfully all normal, so unlikely to suggest a malignancy. So we followed this diagnostic approach, wherein if your PTH is low, normal, or low, we know it's a non-PTH mediated hypercalcemia. And then you measure the PTH-related peptide, which, if elevated, suggests a hypercalcemia of malignancy. We, however, could not send this off because it's, one, quite expensive, two, needs to be sent away, and three, we can do other tests to screen for malignancy. We have to check the 1,25-dihydroxy vitamin D, and if that's elevated, could suggest a lymphomatous process, could suggest a granulomatous process. And then we've already checked the 25 hydroxy vitamin D, which we know is not elevated. So you need to screen for a myeloma. So now we've got help from other teams. We've involved our endocrine colleagues, and in view of the raised calcium and the low PTH rather, we know it's a PTH independent hypercalcemia, and so they've suggested continuing IV therapy, intravenous bisphosphonates, which he didn't really respond to. So we went ahead with giving him IV calcitriol. Again, not really much response to a malignancy screen. And because he has the AKI, the dose of metformin and sitagliptin were reduced. We involved our renal colleagues who suggested that the acute kidney injury is most likely related to the hypercalcemia. But the differentials, as previously explained, could be acute interstitial nephritis. And he went on to have a renal ultrasound that did not show evidence of an obstruction or hydronephrosis. We spoke to our respiratory colleagues for consideration of a biopsy of those mediastinal lymph nodes. We do need tissue biopsy now because the calcium's not responding. He's not doing really well on the ward. For a consideration of an endoscopic biopsy, that versus a CT-guided biopsy of the lymph nodes, both of which were considered not very safe given the location. So we need to find another site, like, is there some other tissue that we can get? So he had a PET scan. And as you can see in the PET scan, the mediastinal lymphadenopathy is quite PET avid. And he's also had some cervical lymph nodes that have lit up. You can see the interstitium of the lungs also lighting up. In the lower part of the bowel, the right lower part of the bowel, there's a little light up there. And this is, as you can see, as explained in this, there's the mediastinal lymphadenopathy, mediastinal and supraclavicular, mediastinal lymph nodes, and the parenchyma of the lungs that have actually lit up. Now that we have another site that can be biopsied, we spoke to our surgical colleagues to organize an excision biopsy of his lymph node. And this is the picture. This is the low power view, which demonstrates just effacement of the normal lymph node architecture by granulomas, and there's no associated fibrosis. And this is the high power view, where it's suggestive of a non-necrotizing granulomatous process, which is, there could be several differentials for this. So it's a non-necrotizing granulomatous process, could be sarcoid, could be tuberculosis. So what the report said, make sure cultures and other tests are all negative, and then you arrive at the diagnosis. And the further blood tests that were pending have all come back by now. The 125 hydroxy vitamin D, which, as you can remember from the previous chart, was suggestive of maybe a granulomatous process, was elevated. His myeloma screen was negative. He did not have TB, and his ACE levels were quite elevated, as you probably would have expected by now. So he has a diagnosis of sarcoidosis. After 2.5 weeks of being in hospital and lots and lots of investigations, we finally arrived at a diagnosis for this man. And our immunology colleagues have been involved by now, and he was commenced on prednisolone 40 milligrams. So everyone's very happy. We have a diagnosis, treatment started. The calcium is also improving, but he becomes really delirious. He's become really aggressive towards the nursing staff, which is very uncharacteristic of him. He doesn't recognize us. We've been seeing him for the last 2.5 weeks. He's not sleeping at night. So as you know, he's been in hospital for so long, so we need to screen him for other causes of delirium. We did a septic workup, chest X-ray, abdo X-ray. He had a CT brain. No cause identified for an acute delirium. So the only possible culprit is likely the steroids. And with reducing the dose of steroids to 25 milligram, his delirium actually improves. Right now, this man is doing quite well. He's being seen by the immunology team as outpatient quite frequently, and he was last seen just last month. He is on azathioprine, a steroid-sparing agent, which he has been tolerating really well. And his steroids from 25 when they started have been weaned down to just 1 milligram. He's had monthly regular blood tests wherein his ACE levels, calcium levels have all normalized. His kidney functions also come back to baseline. And he continues to live at home with his wife, happy, still quite high functional, still driving, and he's done really well. So in light of the diagnosis, I thought we can speak about sarcoidosis just briefly. As we know by now, it's a multi-system granulomatous disorder, wherein there's accumulation of non-necrotizing granulomas and subsequently leading to fibrosis. And this can happen in any organ, which results in the symptoms. But often, this is discovered incidentally when testing is ordered for other purposes. And depending on the organ involvement, you have symptoms. The estimated prevalence is about 60 per 100,000 in the United States and quite similar in Australia. But the worldwide prevalence ranges anywhere from 2.2 per 100,000 in Asia and Taiwan to about 160 per 100,000 in Sweden. And this is quite strongly associated with certain demographic characteristics, including being female, race, and ethnicity. And female patients are often older at the time of diagnosis. But the typical age group is usually between 20 to 60 years. And our gentleman was about 82, so which is what made it quite difficult to actually arrive at this diagnosis. Typical presentations, usually due to abnormal chest imaging, you see mediastinal widening or lymphadenopathy. And if they have pulmonary involvement, depending on whether there's lung parenchymal involvement or thoracic lymph node involvement, could be symptoms like dyspnea, cough, or just generalized symptoms like fatigue, weight loss. Some common extrapulmonary manifestations could be erythema nodosum, as you can see here, or lupus purpura, which is characterized by these violaceous, indurated or erythematous infiltrative plaques, mostly on the central part of the face, on the cheeks and the nose. Could be nodular sarcoid or sarcoid hypopigmentation. The eyes can be involved, and I probably did not show you the lacrimal involvement. I'll go back to that PET scan, sorry. So as you can see here, there's a small light up here, which was his lacrimal gland. So he had lacrimal gland involvement as well. So the eye, any part of the eye can be involved. In the kidneys, our gentleman had renal involvement, which is why, and the hypercalcemia related AKI, but it can result in nephrocalcinosis or nephrolithiasis. And this, if the calcium levels are left untreated, can result in chronic renal failure and thereby end-stage renal disease, or even sarcoid-related interstitial nephritis. The cardiac system can be involved. So our patient had a PET, cardiac protocol PET. His cardiac system was not involved, thankfully, but it can result in conduction system diseases, conduction delays, tachyarrhythmias, cardiomyopathy, heart failure, and very rarely coronary artery disease. Sarcoid can involve the peripheral or the central nervous system and any part of the endocrine system, as you can see, and even the salivary glands. Peripheral lymph nodes can be involved. Patients can have splenomegaly. So if you get a patient with splenomegaly on the exam, it could be sarcoid. The stomach is in the gastrointestinal tract. The stomach is apparently the most common organism to be involved, but again, any part of the GI tract can be involved. And some patients can have an acute polyarthritis picture, especially involving bilateral ankles, which can then become chronic arthritis because of periosteal bone resorption, or they can even have muscle involvement resulting in diffuse granulomatous myositis. So basically, sarcoid can involve any organ. And this is a table from UpToDate from an Access study that just shows basically the organs that can be involved. Most commonly the lungs, followed by skin, lymph nodes, and so on. I thought I'll just put this in. Some pathognomic syndromes that are highly specific for sarcoid is one, Lofgren syndrome, wherein approximately 5 to 10% of patients can present with acute onset fevers, hilar lymphadenopathy, and erythema nodosum or bilateral ankle inflammation. There's also uveoparotid fever, in which they can have anterior uveitis, bilateral parotid gland involvement, because of which they can have facial nerve palsies, and then fever, which is an uncommon presentation, but just so you know. And then there's lupus pernio, the picture of which I showed earlier. And because it's relevant to the patient cohort that we work in, I thought we should speak about steroid-induced psychosis or delirium just very briefly, which is explained in the DSM-5 criteria. It's quite underreported, but it's an uncommon disorder, but likely because it's underreported. And it's usually a diagnosis of exclusion. So if someone's delirious, they're on steroids, you make sure there's no other cause for delirium. It's a dose-dependent issue, and the incidence rates really range from 1.8 to 57%. And the diagnostic criteria for this is that the patient must have either delusions or hallucinations after exposure to the medication capable of causing the symptoms. Symptoms cannot be better explained by a non-medication induced psychotic disorder. They should not already be delirious prior to the start of the steroids. So it does not occur exclusively during the course of a delirium. And it must cause clinically significant distress or functional impairment to the patient. How soon can steroid-induced psychosis set in? Anytime. Can happen immediately after starting the steroids to even after up to 6 to 8 weeks after stopping the steroids. But most commonly occurs within the first week of initiation of treatment. And the median time of onset is usually about 11.5 days. What are the symptoms of steroid-induced delirium? Commonest symptoms in short-term treatment, euphoria and hypomania, but with long-term treatment, patients are quite depressed. There can be mood disorders or psychosis, and even cognitive impairment with long-term steroids. How do you manage steroid-induced delirium? Educate your patients before you start them on steroids. Tell families, if you see any difference, let us know. Avoid overstimulating environments or if overstimulating the patient, and carefully watch for any thoughts of self-harm. And depending on what symptoms the patient has, if they're having mood or affective symptoms affecting their affect, this can take up to 6 weeks to improve after discontinuation of steroids. Psychotic symptoms can take up to a week or more for them to return to baseline after you stop it. Delirium usually a few days to maybe a few weeks. And the first thing you do is try and stop the steroids or get rid of it, or taper the dose based on what bigger dose they were. Taper as quickly as possible to return to physiological doses. And if you're unable to wean steroids or the psychosis is really bad, you could consider atypical antipsychotics or mood stabilizers. You tend to avoid TCAs for this. And if the patient's at significant risk to themselves or to people around them, there's significant thoughts of self-harm, you involve the psychiatry team for consideration of ECT. I'd like to call Dr. Saha to conclude today's talk.
Hi, so my name's Dr. Saha, one of the geriatricians in the hospital. And the reason I picked this particular, we picked this particular because it's interesting. This is the first sarcoid that I've diagnosed in a geriatric population. I know when we were going through the diagnostic processes, the immunologists were telling me, this is really unheard of, Sabari. It cannot possibly be sarcoid, because I kept saying, let me give steroids, and they were just like, yeah, don't do that, you'll really mess things up. His calcium was just continuing to climb, despite being on fluids, diuresis, despite IV bisphosphonates. We even gave him some calcitonin as well. And in spite of all of that, his calcium was still about 3.41. And surprisingly, he wasn't confused. Didn't feel crash hot, but he wasn't confused. And I guess the other reason we picked this was because all of a sudden, when we gave him a medication that was supposedly supposed to fix him, from a cognitive point of view, he got really, really bad. And, at that point in time, that was really the only thing he had that was going for him, that was his good cognitive function. So he went off really, really quickly after the steroids were started. As you all know, hindsight is really, really good. Now that I look back on it, I'm like, oh yeah, that was all good. But I know when I was actually going through looking after this patient for the very long 3 weeks, it caused tremendous amount of anxiety because we didn't know the diagnosis and hence we couldn't do the treatments, which is why we chose the title of the topic, that coming to the correct diagnosis is 3/4 of the way to the proper therapy for the patient. Now, as we all get older, we're going to realize that cognition is actually a really important part of our well-being. To be able to think clearly is actually one of the sort of basic sort of comforts in life. And when that all of a sudden goes, that actually impacts not just that individual, it actually impacts their family, the nursing staff looking after them, the medical staff as well. And delirium is very common in a hospital type of setting, and there's so many contributing factors to it. If you guys put yourself in a hospital for a week with unknown diagnosis, I guarantee you'll become a wee bit delirious as well, with all the noise around you, etc. And put yourself on a ward full of patients with dementia, with the noise, etc. That in itself can be quite disorientated. So for me, this actually gave me a nice mix of geriatric medicine, and treating the underlying problem actually helped me kind of fix once we got the levels right. And we were able to get the patient home, and 4 years on, he's still alive. A lot of our patients sadly don't last that long. Also, the other thing is functional decline. We are often referred patients from ED, from the community, with functional decline. It's so non-specific. There's so many things that could be contributing to it, and it's often multifactorial. And this was one of those conditions that was a very rare cause of that functional decline. So for me, this found a nice little mix of geriatric medicine along with other things as well. And I just thought we could just sort of discuss that. It's really, really important that we do get to the final diagnosis, because we can actually give back this patient their sort of quality of life. But we always need to understand that all medications have side effects. We've got to be very smart about this. Any questions? If you got any sarcoid questions, don't ask me. We do have an immunologist, but if you've got any burning sarcoid questions, we've definitely got an immunologist here. If you've got any delirium questions, yay.
I just have a comment.
Yes.
And there are a few lessons that we have learned from this case, but I think one of the lessons is that, yes, we have stats, we have prevalent age, but we have to, as a clinician, we have to keep our mind open. The only thing in this elderly gentleman with sarcoidosis is his age, because top of the list would be malignancy, whether solid organ or hematological malignancy, myeloma. But then, if this patient was young with all the lymphadenopathy and acute kidney injury, hypercalcemia, you would not think about malignancy, you would straight think about sarcoidosis.
Yeah.
So yeah, I think as a clinician, you just have to keep it open.
Yeah, as I said, very, very true. And that's why, we presented it, because rare things can happen in elderly. So let's not just block ourselves off. It's potentially treatable. Not me.
I think that's a point that's very well made, Sabari. Do we have any other questions? Oh, hang on.
So the question from Kavya first.
Question first off the back, very back row.
Sarah, on the street, I will look in you wish.
I'll just repeat the question. So I think what's the question was about the dose range and duration of steroids that are liable to induce a delirium. Is that correct?
Yeah, so I guess from the literature, they say usually doses above 40 a day can usually are more likely of causing it. But I've seen patients even with, say, 10 or 15 milligrams that have become a bit delirious. These are usually patients who already have underlying cognitive issues, so they're going to be a bit sensitive anyway. But if you've got sort of normal cognitive function, apparently around 40 milligrams, and that's why they say try and taper it down to 25, because that seems to be a more acceptable dose. Was there am I doing something?
No, I'm not sure what's causing that, but anyway. I think we've got a few more questions, but Michael had a comment.
Really just stating the obvious, it's a very nice elegant presentation, thanks. I just thought it's worth pointing out, and from Sam here, that, you know, one of the early things to do in the investigation is protein chemistry, protein EPG, IEPG and light chains. Now, of course, as you well know, myeloma is a common cause presenting with hypercalcemia, eminently diagnosable, eminently treatable disorder.
Thank you. And we were reminded that halfway through the course, so we eventually did it.
Yeah, I think in this particular instance, obviously there was some other clinical factors that would argue against the diagnosis from a clinical standpoint, but I think if you look at that diagnostic algorithm that was talking about vitamin D, I wouldn't bother getting into that, just do the imaging and the light chains. Other questions?
Does the being on the ACE inhibitor interferes with the ACE levels?
That's a very good question. Does being on an ACE inhibitor?
Yeah, it does. Yeah. So, no?
Did you have a comment here?
Yeah, so I read that last night. Yes, it can. So it can suppress it, but there are lots of things, and that's the other sort of conversation we had with the immunologist, because we said, well, the ACE is really high, it must be sarcoid, but lots of different things can cause an elevated ACE level, such as lymphomas and other granulomatous diseases, some cancers as well. So it's non-specific, but you know, and you're being on an ACE inhibitor, which he was on, can suppress it, but his was elevated despite that.
I'm going to comment.
Yeah, sure.
So hi, I'm Geri, one of the immunologists. Thank you so much for that presentation. It was great. So yes, just following on from the comment, the ACE level by itself is very non-specific.
Yeah.
Some of our patients in our clinic have raging florid sarcoidosis, but have from the beginning until the end of monitoring and with disease progression, completely normal ACE levels. The only other thing I thought to mention is, which you briefly covered in your talk, is that sarcoidosis is, as many of us know, a diagnosis exclusion. So it is not uncommon to have very convoluted journey to the diagnosis. But what really helps is tissue, which is absolutely vital. And we really want to make sure that there are no infections. So you mentioned other infections that cause granulomatous or granulomata, and also malignancy, because we don't want to get down the line a few years after having immunosuppressed the patient, realise, well, maybe it wasn't sarcoidosis after all. So tissues really key. And the literature says, you know, approximately up to about 10% of patients with sarcoidosis present like this with hypercalcemia. And it's not, you know, that rare that we have kind of very severe hypercalcemia and need steroids before tissue. But by the time they get to clinic class, we try and always wean them down and get a PET and get a tissue diagnosis.
Yeah, thank you.
Thanks very much, Geri. I think that's something that we certainly agree on as hematologists. We love them tissue. Any other questions?
No delirium questions.
I have a question.
Go for it.
What do you think was the cause of the abdominal quadriplegia? Do you think you had gastritis due to the sarcoidosis?
So basically, a couple of things. If you have a look at his PET scan, just in the right lower region, it lit up a wee bit. So I'm just wondering whether he's got a bit of sarcoid there, which, you know, might not sort of need immediate intervention. But the other thing is his liver function test was just very mildly abnormal, very mildly. And I'm just wondering how much of sort of sarcoid in the liver he had. We couldn't see any nodules or anything, but it's more of an infiltrative process. So it could be that, but he was also a large man. So he could have sort of a fatty livery sort of thing as well.
Just on that note, Gary, did you follow this patient for?
No, it's Gary's patient.
Know if the liver function test normalised with the steroids? Is that
A bit,
probably good?
just a wee bit, but not completely. And he's actually seeing a gastroenterologist.
Just had one question, so when we did not know that this patient has sarcoidosis diabetes
Yeah,
and his calcium was rising,
yeah,
was the thought of giving steroids came like
multiple
steroids, which
Yeah, so the question was, did you ever think of giving steroids when the calcium was just right? Multiple times. In hindsight, I'm glad I did it, not because of the diagnosis, it's that ill impact on that, because he had lots of side effects from the steroids. The steroid-induced psychosis was one of those. The second thing was his blood pressure just shot up. Thirdly, started developing really bad epigastric pain, and poor Armo was called every night to see him. And the last thing, I think he's got his blood sugars sort of still creeping out. So steroids are amazing, but they're a very dirty drug that's multiple side effects, as we see in this patient. And if I had actually given it before a formal diagnosis and it turned out not to be sarcoid and he didn't actually need steroids, I'd be rectified. So for my own piece, I'm just like, okay, we did the right thing. We waited, then we gave it to him, and then we made him really sick.
Any other questions?
And once we reduced the dose of the steroids, honestly, he was so good. He was out that door of 11A within 12 hours. His wife's like, I'm taking him home. I don't want anything else to go wrong. So he's happy.
I just wondered the other question. I mean, obviously this patient was a smoker, but was there any chance that the prior history of COPD was in fact not verified and he might have had pulmonary sarcoidosis the whole time?
Completely possible. However, he was known to a very good respiratory physician. So I'm 100% sure he did not have sarcoid before.
thank you.
Well, we might take an early mark. Thank you very much, Sabari and Kavya.
Thank you very much.